While everyone's shuffling up here, let me just welcome this next panel. Dr. Walson is going to start first, so conveniently located here already. After you, please.
And that is really, now that we have shown some data and some suggestion that these campaigns are feasible, they reach very large segments of the population who may otherwise not be reached for these interventions, and they combine these interventions in a cost-effective manner, and there may be some ancillary benefits to the HIV-infected population. The question is, if you were going to do this, where would you do this, and how would you decide where it's beneficial and where it would make sense? Not everywhere is the same as Western Kenya. So I'm going to just present a very quick overview of the methodology we use to try to look at this question. I want to point out that this is work that we initiated in response to a request from the Bill and Melinda Gates Foundation for a program called the Strategic Applied Research and Training Program that I co-direct at the University of Washington. In fact, one of our students who works at that program is here. And we provide analysis support to the Foundation for strategy planning, etc. And as part of that, they had asked a very similar question about another intervention looking at childhood mortality and wanted to know if they were going to scale this up around the world, where would that make the most sense. And so we used a similar tool, which we've now developed for answering this question. The idea is to really look at different opportunities by country, as well as the feasibility of implementing an integrated campaign to deal with HIV, malaria, and diarrhea. The idea of this index is to be able to summarize a huge amount of data from very disparate sources and to look specifically at burden of diseases that may be impacted by the campaign. The idea is to look at existing interventions that might also be there that are competing for risk reduction and facilitate the identification of countries where the opportunity is greatest. So what we've done is created this opportunity index. Please do not try to read it. The goal of this is not to actually read any of the text on this slide, but rather to see that what this tool does is provide a very visually compelling, easy to read summary by country of risk in terms of diarrhea, malaria, and HIV, which are listed across the top, and for each of the indicator variables, which I'll quickly walk through, specifically color code the opportunity as high or red, medium or yellow, or blue or low. And we picked those colors because the graduate student who was working on this was colorblind, so we had to pick colors that he could actually see. So this shows now how we've done that for this analysis. So here are 10 countries listed by the total DALY burden calculated for the DALY burden of diarrhea, malaria, and HIV. And the first thing that should strike you is there's a lot of red on this table, which suggests a very high opportunity. So I'm going to walk through just what makes up this opportunity index quickly. So I've removed the countries so that they're not distracting for people who are sitting there going, I'm from Uganda, where's Uganda, I'm from Kenya, you know. I think it's easier to look at blank. But the idea is that you have the country, the total DALY burden, the DALYs per capita, because it's important to recognize that the total DALY burden is driven largely by population size. So countries such as Nigeria and India are going to have incredibly high DALY burdens just because of large population, where countries may have very high per capita DALY burdens, but because of small population size would not necessarily be reflected accurately. The total population size, which is necessary to calculate that, the under 5 mortality, overall mortality rate, life expectancy, and then we move into these disease-specific indicators. And again, I'm happy to stay after and answer where we got these source information. They're from a disparate group of sources, including World Health Organization, UNAIDS, IHME, a variety of other sources. The diarrhea burden, annual deaths due to diarrhea, the DALYs attributable to diarrhea, and then we did look at competing interventions. So what percentage of the population already is reported of having improved drinking water coverage of any sort, be it chlorination or any other. We also looked at malaria and HIV in a similar way. We looked at the burden of malaria by WHO criteria and IHME criteria. The reason for both is because they don't agree, and we want to be sure that everyone's happy. We included annual deaths due to malaria, DALYs, and then the total percent of the population living in a malaria at-risk area or a malaria endemic area. And then the current coverage of ITNs in that population. And then for HIV, we looked at burden, deaths, DALYs. We looked at pregnant women who had the percentage of pregnant women getting tested as a surrogate of coverage of testing. because that is the most readily available indicator. And we looked at the coverage of ART among individuals in that country with CD4 counts meeting WHO criteria. So that gives you a sense of what makes up this opportunity index. And so when you fill it in, you start to see the numbers and how they play out. But what this does is allows us to quickly assign an opportunity score or weight to each country and allows people to see where opportunity may exist. And I think there's a couple things that are quite striking about this. Number one is, as you go down the table, you'll see that even in countries where malaria may not be a tremendous problem, or where drinking water coverage or improved drinking water coverage is better, you still see incredible opportunity. In other words, there's still an incredible DALY burden that can be addressed through these campaigns. So the idea that, well, this country doesn't have a lot of malaria, therefore the IPC doesn't make sense, actually may not be as relevant as we think. And of course, the campaign can be modified or tailored as needed. This is just to visually show you where these DALYs are happening. If we do it by capita, it's not surprising that sub-Saharan Africa and parts of Southeast Asia really make up the burden of that. And when we look at total DALYs and we do a cartogram, which weights countries by the actual DALYs, it's quite an interesting picture, and you can see that Africa really just stands out quite dramatically, but so do parts of South Asia and Southeast Asia as well. But of course, when we talk about something like these campaigns, it's important to recognize that we all know there's a lot of opportunity to make a difference, but it's also not just the opportunity. We also have to make sure that there's feasibility. So where countries are prepared to roll out a campaign of this nature. So we developed a feasibility index which looks at these different variables, which I won't go into in general or in detailed terms, but just generally to say that what we looked at were really the presence of violent conflict being an impediment to these types of campaigns, levels of corruption, and then government investment in health as a surrogate for how prepared the government is to invest resources, time, and energy in making these types of campaigns happen. And we then grouped these also into different feasibilities. And you can see red would be high opportunity, meaning lower levels of corruption, less conflict, etc., where blue is less opportunity, meaning higher levels of corruption or less expenditure by the government, etc. So you see a little bit less red on this feasibility index, but this can be generated for any country in the world. In fact, we've done that. And what we think the way to move forward with this is, and just as we did with the work at the Gates Foundation, would be to expand on this for individual countries who might be interested in this type of a campaign and provide a country profile which really expands on very specific regional and district level differences in the opportunity and feasibility across this, provides subnational information where possible, and provides detailed information for planning and implementation. And I think if there's interest in doing that for any specific country, we'd be happy to discuss that.
So I want to present a projection of the results that you've heard from the West Kenya campaign, using the empirical and model results from that campaign and applying appropriate adjustments for epidemiological variation and cost variation in a large number of countries. So we looked at 100 countries, and we created an index very similar to the one that Judd just described that focuses on the disease burden per capita. So it's a sort of way of controlling for population and looking at the intensity of burden per person in each of, according to this slide, the top 10 greatest opportunities. So these would be the countries, starting with Zimbabwe, where the per capita burden is greatest, and ranging down to Uganda, where among the top 10, the burden would be the lowest. And we calculated the cost of the IPC campaign and then presented an adjusted cost, that is the net cost, which takes into account the averted treatment cost for disease that's been detected, and adds cost for disease that's been detected where treatment is required, and there in particular HIV, since we're capturing a lot more, we're identifying a lot more people who otherwise would have gone untreated. You can see that in some cases, the high HIV prevalence cases, the net costs are actually higher than the program cost itself. Nevertheless, in 3 of these countries, the program was cost saving rather than having a positive cost. This is the same cost data, but presented from the benefit point of view, cost per DALY averted. Again, 3 countries had cost savings indicated by the 0 cost per DALY. South Africa, which is the least cost effective among these, I want to emphasize on any appropriate scale, $200 per DALY for a relatively affluent country like South Africa, highly cost effective. The cost effectiveness of this intervention can be put in greater relief if you use the cost effectiveness of antiretroviral treatment as the threshold or the standard for cost analysis. So the blue lines that you see in this graph are exactly the previous cost effectiveness lines for these 10 countries, and you can see that the cost per DALY for antiretroviral treatment is much, much higher. That is much, much less favorable than the results that are achieved in this campaign. It gets better. In a second round of the campaign, we would expect to have a far smaller number of HIV-infected people who would require further treatment, because the first round would have already identified and put a large portion of those in treatment. So in many cases now, we see costs shift from a net positive cost to cost savings. And in this scenario, 7 of the 10 countries actually enjoy cost savings with the advent of the IPC campaign. In parallel to the first campaign, this presents the cost effectiveness ratios. And as you can see here, we've gone from 3 countries with net cost savings to 7 countries with net cost savings. Extremely modest cost per DALY averted, extremely favorable cost effectiveness ratios, even among those countries that show a positive cost. We then expanded our scope. Up to this point, I've been talking about the 10 countries where the opportunity is the greatest. But we moved from that 10 to 25 and then to 40. So we moved down the scale of opportunity to include more countries. As you would expect, the cost of the program, that's the 3 columns to your left, increase as you add more countries. And at the same time, the net costs on the 3 columns on the right decrease. That is, greater savings are represented as you add more countries, up to a savings of about $1.4 billion for the top 40 countries that we analyzed. We took what I believe is a conservative estimate of coverage, 15% of adults, representing about 1/3 to 1/2 of eligible adults in each of the countries we included in this analysis. Here's the health benefit side of the same equation, going from 10 to 25 to the 40 most attractive opportunities for this type of intervention. And DALYs go from roughly $17 million for the top 10, $37 million averted for the top 25, and $42 million averted if you move to the top 40 countries. So major health benefits are possible here. And I would summarize the result of this quick survey as a strong indication that, taken to scale, IPC can be highly efficient and an effective strategy for improving global health and saving on safe public health resources. Thank you very much.
I was tasked with providing the funder's perspective. I'm not a funder, and the world should be grateful for that. Not much would happen if I were. I'm a health services researcher at Stanford, but being thus removed, what I will do is set up the challenges for funders in the context of integrated prevention campaigns that I hope will be seeds for discussion later in the panel. If I had to pick out and point out 2 principal themes of policy themes of this meeting, it would be these. The first is that there is this palpable excitement and anticipation about the promise and commitment for increasing the treatment and prevention for HIV. And the second is that donor support to bankroll these expansions in treatment and prevention has not increased for several years. In short, the charge is really to do more with less, or really to do more with the same. But there's a broader debate here than just about HIV. On Monday, this foursome, at least 25% of whom are here in the audience, fiercely debated whether health aid for HIV is a good investment. Mead Over and Roger England on the left here were against the proposition, repeatedly emphasizing that investments in clean water, malaria, among others, among other health priorities, are really better bargains for the scarce health dollars. The implied suggestion is that better health can be achieved if the health aid portfolio were rebalanced. On the face of it, this would create some tension between a kind of portfolio where more people are on ART or on other preventive strategies for HIV, and the kind of portfolios where there are sort of more that include more best buys. But this panel here suggests that there's a middle ground. Integrated prevention campaign can reduce the costs to the donors while doing more. And this is clearly how. So I'm going to talk about the donors here. Many of the analyses that we've seen were from a societal perspective, but even from a donor perspective. Imagine Kenya. Don't imagine too hard, because this is really the targets for the aid agencies. PEPFAR wants to increase home-based and volunteer testing. Yes, does the Global Fund. The President's Malaria Initiative and the Global Fund are targeting to increase possession and use of insecticide-treated bed nets and long-lasting insecticidal nets. USAID and CDC are testing and implementing different clean water technologies. These are the views from the donor's eyes. And imagine, put yourselves in the donor's eyes, and this is the no-brainer. The costs for doing all of these things would be lower if they were implemented in synchrony. So why is it so hard to coordinate? This is from the President's Malaria Initiative's website. The goal of PMI is to reduce malaria-related deaths by 50% in 19 countries in Africa that have high burden of malaria by expanding coverage of 4 highly effective malaria prevention and treatment measures. Just malaria. The Global Health Initiative, set up by the Obama administration, set out or aimed to bring the various US institutions involved in health aid under one umbrella. In the words of the President, we cannot simply confront individual preventable illnesses in isolation. The world is interconnected, and that demands an integrated approach to global health. But the Global Health Initiative also lacks statutory or budget authority, and to date failed to eliminate many of the parallel structures in the major health aid agencies. It's a human irony that some of the world's finest minds are occupied with solving no-brainers. I'm not proposing to know any solutions, but I'm going to put a few things out there that I hope will be addressed in tonight's third act. One is you can create a common fund for cross-agency priorities managed by the Global Health Diplomacy, which is the incarnation of the Global Health Initiative. Another idea, funding specific aspects of ministry campaigns could promote the breadth and ownership of ministry activities while keeping donor priorities and outlays aligned. In fact, this could be a good way and a good idea to increase country ownership. Ministries have a broader, holistic view of campaigns, are much more willing and ready to implement integrated campaigns. Funding particular aspects of these or complementing them could be a way of allowing the ministries to take more ownership, at the same time keeping the donors' interests aligned. I live in Silicon Valley, and I wouldn't be allowed back in there if I didn't mention something about innovation. And so you can imagine new and creative, new and innovative approaches to health development aid. If donor agencies are told or encouraged to dedicate a small portion of their portfolio to creating and finding new innovative funding and disruptive approaches to improving global health, could allow expenditures on integrated campaigns. So far, funding integrated campaigns through the traditional siloed approaches has been difficult, but this can change. Thank you.
Thanks for your introduction. I'm going to talk about the broader opportunities and challenges of these integrated prevention campaigns, which I call IPCs. Briefly, just a summary of the menu. I'm going to talk briefly about synergies of these IPCs, potential synergies, potential equity gains, potential opportunity cost as well as how we can fit that in a broader health system integration perspective. So to start with, so we can see really this integrated prevention campaign. So I'm going to talk about 20 times about IPCs, which is the campaign we've referred to here. We can see this IPC as one platform or more among the bigger health system, one health system delivery platform where you have policy instruments like universal public finance, taxation, conditional cash transfers, which are funding different delivery platforms. So if you think about HIV/AIDS and adult health, one delivery platform is IPC, as we said, and then you can also naturally think of an HIV dedicated clinic which provides on a regular basis ART medications to its patients. I'm also putting a parallel here which is quite interesting for that work with child health and immunization, where you have different delivery platform mechanisms. You have routine vaccine services, deliver the typical antigens, as well as recurrent child health days, which are mass immunization campaigns, quite similar but different interventions than IPCs. So if you look at IPC, the IPC platform, it delivers VCT, refill to ART, ITNs, water filters. It's very easy to understand that we already have an infrastructure in place, so at very low cost, probably, we can make a huge impact. The impact probably depending on the different interventions you get in the synergies that we have, biological, logistical, and also obviously depending on the underlying epidemiology and the pre-existing level of coverage for key interventions. One appealing aspect of IPCs, which we haven't touched upon here, is by their own design, the IPCs are actually trying to reach out to underserved populations that are not using health services on a regular basis, marginalized populations in remote areas. So it would be interesting to study the effects of alternative strategies, IPC strategies, and health disparities among population subgroups that can be geographical locations, urban, rural, for example, an easy one to think of, or wealth status. And the question being, can IPCs actually be a mechanism to target the poorest? In the same time, implementation of IPCs, and Eric touched upon the logistical aspects here before in the previous panel, requires a large health workforce. There's a certain potential diversion from accomplishing routine duties. In fact, there might be negative impacts on the health system when you think that maybe because there's a huge mobilization of some workforce, interruption of some services may happen in clinics or hospitals. One way that potentially you could limit the opportunity cost, as I call it here, is probably using non-technical workers. We're thinking obviously of community health workers, and also prioritize simple interventions that indeed require unskilled workers. I'm going to take a minute here to make a parallel with the child health days again in sub-Saharan Africa. So these are mass immunization campaigns that usually last 1 to 2 weeks, depending obviously on the size of the country. They're centered around the delivery of polio and measles vaccines, around basically the polio eradication initiative, and now the measles elimination goals and that are currently in place. But they also deliver cheap, low-cost interventions, IDNs, bennets, vitamin A deworming medicines. So we did some work in South Africa, and just to touch upon a couple of things, we found that the sole inclusion of vitamin A supplementation onto that delivery platform makes the intervention, the delivery platform, much more cost-effective than just delivering measles vaccines. We also found that during implementation of the campaigns, we found a significant decrease in routine health services, well, especially tied to maternal and child health. So to take it to a broader perspective on the health system, I think there's a couple of connections here. First, we're targeting adults, so this is really an opportunity to include other adult health interventions. So it'll be easy to think of, as we have HIV, malaria, the missing one is tuberculosis. But there's also the opportunity for leveraging the infrastructure already in place for non-communicable diseases, such as risk factor screening, maybe tobacco prevention. And there's also the higher perspective, higher level, which is maybe a way to strengthen health services, because we have a platform which is integrating vertical disease programs and intersectoral policies, and that also links communities to basic health services. And in that respect, there's an interesting precedent which Jaime Sepúlveda was directly involved with, which is the Mexico National Health Weeks, the Mexico's National Health Weeks, which was a child health delivery platform for immunizations, as well as low-cost interventions, deworming, vitamin A, rehydration salts. Thank you very much, and I'd like to thank everybody who contributed on this panel. Thanks.